Hello, JMIR followers. This is Dr. Jennifer Joe, JMIR Ambassador. Today, I'm interviewing Dr. James Bailey, Executive Director for the Tennessee Population Health Consortium at the University of Tennessee Health Science Center. Dr. Bailey's ongoing research focuses on patient-centered improvements in healthcare delivery, quality of care, and health outcomes for people with multiple chronic conditions in underserved areas. Today, I'm delighted to be discussing Dr. Bailey's research published in the Journal of Medical Internet Research, Early Patient-Centered Outcomes Research Experience with the Use of Telehealth to Address Disparities, a Scoping Review. Welcome, Dr. Bailey.
Thank you. It's good to be here.
And just for our listeners, where are you?
I'm in Memphis, Tennessee. Tennessee, the Graceland.
Dr. Bailey, with Figure 3 as a guide, can you walk us through PCORI's priority populations that were studied?
Absolutely. The studies we reviewed and considered in this scoping review all had some focus on PCORI's priority populations. And those are racial and ethnic minorities, first and foremost, residents of rural areas, lesbian, gay, bisexual, and transgender people, and people with low health literacy, numeracy, or limited English proficiency. And then the other two priority populations are low-income people and individuals with disabilities. So we looked at the broader range of PCORI-funded research and selected the studies that use telemedicine as a way to address disparities in those populations.
Figure 2 as a guide, can you talk to the 41 studies that were used in this review and why it was so impressive that we had these 41 studies?
Yes, you know, PCORI has made a tremendous investment, both in addressing problems related to disparities and looking at the sorts of interventions that are most likely to benefit people at risk for disparities. But this review focused particularly on their telemedicine portfolio, which is quite extensive. All 41 studies that we selected that met our selection criteria. And those were essentially all PCORI funded studies that assessed the comparative effectiveness of some sort of telemedicine approach in populations at risk for disparities.
Absolutely. Before COVID-19, the biggest concern for delivery of telehealth was access to technology. In your paper, you highlight that more than 90% of Americans carry cell phones and 80% have smartphones. Among people with household incomes less than $30,000, 71% own a smartphone, 54% own some type of computer, and 56% have home broadband. Can you talk about two or three of the barriers that were encountered, maybe the top ones, and give our audience some specific examples or colors of what those barriers actually look like?
One of the things that we saw virtually all of the PCORI funded studies do was to take special measures to overcome those participant barriers related to social determinants of health. Sometimes that was direct subsidies of telehealth modalities, technology, computers. One good example I can use is our own model study, the management of diabetes in everyday life, which was included in this review. And it actually employed one of the key lessons learned out of this paper, which is patient-centered design. We asked patients, what were the types of technology that you would find most helpful? And we got a resounding response from the community that we'd like to get text messages from our healthcare providers. We'd like to have personalized, relevant text messages from our doctor's office to keep us connected and on course with our therapy. And we heard from patients, we don't all have smartphones, but we all have cell phones. And everybody, even our elders in low-income populations, are using or at least receiving texts. So in our case, we found out it wasn't the fanciest technology. Another good example of that would be having that we identified as an inadequate program supervision management barrier is the technologies need support people. And the support people have to be patient-centered, responsive, friendly, easy to get access to. So many of the telehealth
you're describing the healthcare system, and we're so good at that. Sorry.
Right. Communication.
We're
Yes, sometimes the old-fashioned technology is the best, right? Just having somebody answer the phone when you call with a problem.
And a friendly voice who sounds like they care. I really liked how you analyzed and called out some of the operational organizational drivers, specifically around system level barriers for financial reimbursements. Can you speak to that? And I talked to this because we know that the finances have to work in order to actually drive adoption.
Oh my goodness, isn't that the case? And that has been such a huge issue in the era of COVID-19. And of course, with the public health emergency, there has been authorization for the use of many of these telehealth visit codes, for example. And already we're seeing that pulled back, which is very discouraging, particularly given all the evidence we have from these studies and others that mental health counseling, that support for diabetes care with health coaching, for hypertension care, for COPD care. Our studies covered, the PCORI funded studies covered a range of chronic illnesses primarily, and people with multiple chronic conditions. But the evidence is clear that these telemedicine modalities are effective in many very well prescribed areas, and that they tend to be as effective and sometimes more effective than traditional face-to-face visits. So this was something we heard clearly from all of the studies, and their difficulties moving to sustainability was the importance of working with the payers to assure reimbursement and come up with agreed upon reimbursement strategies. And that often, getting to that agreement often requires policymakers to be involved and advocating with best evidence for reimbursement of appropriate telehealth care.
Oh, I just love how you said that. That's so important. And what I'm really hoping is that great studies, evidence, massive bodies of evidence, as which you've aggregated here, will really help arm our policymakers to have that discussion, or arm our clinicians to have that discussions with the payers, so that we can make telehealth a sustainable model moving forward.
Can I add one thing, Jennifer? You know, we think of a lot of our projects advocated for and made arrangements in some cases as they moved into sustainability for fee-for-service payment reimbursement for telehealth services. On the other hand, the projects in highly managed areas where there's a lot of value-based purchasing, these services, as they're demonstrated effective, are increasingly provided by the provider themselves as part of their service package to more effectively manage care. And under value-based reimbursement, it's a real bonus to the organized health system. So I think the market is really moving in this direction. That's one thing we heard from our from the PIs participating in many of these studies, that value-based care and purchasing of healthcare actually helps facilitate this kind of care across the spectrum of illness.
Oh yeah, absolutely. That's so well said. As I mentioned before, I appreciate that you have highlighted the systemic issues that remain major headwinds, and some of the licensures and issues with where the patient is and where the physician is are part of that you've highlighted that, I think we need to aggressively address. So now let's get into the meat of delivering amazing telehealth services that can meaningfully close the gap in disparities. Table 2 really focuses on that, which are what are the facilitators, what are the top facilitators to telehealth adoption, and specific examples of that, because we want to take what you have already learned and just deliver amazing care in a new system.
We looked at competency drivers, organizational drivers, and leadership drivers. But on the competency front, the major thing that so many of our projects mentioned was around the need for improvements in participant engagement, that we needed approaches to engage patients in efforts to address their social needs and facilitate their telehealth adoption. So there were lots of ways the projects did this. One was through provision of access to telehealth technology, but all of our projects, virtually, at least half of them, identified patient-centered design is critical. Employing telehealth solutions that were actively guided by patients to meet community needs. And as you said earlier, and we discussed a little bit earlier, they all needed to be accompanied by improvements in staff training, and specifically training in patient empowerment techniques, such as motivational interviewing, to facilitate telehealth adoption. We think of motivational interviewing as being an empowerment approach that works in face-to-face counseling, but it also has a role in helping patients adopt tools, telehealth tools, to help them improve their own health.
So it's really important for people to understand the concept of cultural tailoring. We've seen the importance of diverse groups and making sure that we're going to them, and also opening the doors. I think the unrest of the last 2 years has really highlighted that. And you've really illustrated the importance of cultural tailoring. Do you have an example for our listeners so that we can really dive into that?
Really, cultural tailoring is the heart of patient-centered design, right? It's using the words, the language, the images of the culture you're attempting to serve, painting pictures in a familiar language. And a great example of that was the Healthy You Salute Tu study, which was out of Los Angeles. And the study aimed to assess the effectiveness of a patient-centered, computer-based clinical intervention. They actually used an app to reduce health disparities in unintended pregnancies among Latina adolescent girls. And adolescents themselves and local community representatives were key stakeholders in the design and implementation of the app. And the investigators thought that was really critical to its success. The culturally tailored tool was available in English and Spanish, even though it targeted a Latina population. That population really wanted both, and they adapted language that resonated with Latina adolescents. Similarly, with our model project, Management of Diabetes in Everyday Life, we did extensive vetting of our text message library. We use tailored text messaging in the model study. And that library was extensively vetted by the African American population we were serving. And we learned a lot through that process. People didn't want preachy messages. They wanted inspirational, encouraging messages. Nobody wagging the finger. And you know how language can do that. Listening to the community you're serving and using their language is absolutely critical to patient engagement in telemedicine modalities.
I love that. That is so important to really understand, see, touch, understand what cultural competency and patient-centered design is. So thank you for sharing that. In closing, can you talk to what are next steps in either research, collaboration, policymaking that we need to think about as a whole to ensure that patients in the United States are getting the best care possible and leveraging the technology that's available to us?
Absolutely, Jennifer. That's a great question. First, in research, I think we really do have to move into the world of dissemination and sustainability research to look at the factors that contribute to sustainability and test specific approaches for dissemination and sustaining telehealth modalities on a broader scale that we've proven are effective. On the collaboration front, I think this group of studies calls to the importance of engaging patients at every stage of clinical care and health system improvement. So one natural conclusion of this work, this body of work, is that we should expand our use of patient advisory councils, or often called partner councils, that can inform the work of health systems to deliver culturally appropriate, culturally sensitive, and ultimately effective solutions, right? So engaging patients and key partners in every health system, that's not really been done in a systematic way, right? And we can do that, right? We can engage patients in our quality improvement teams if we're intentional about that. On the policymaking front, I think undoubtedly we have to think about telemedicine reimbursement and having more encouragement of health systems to deliver these proven solutions and tailor them for their own populations, but deliver these proven solutions more routinely. Many of them are very low cost and not hard to implement.
Absolutely. Really inspirational sitting down with you, Dr. Bailey. Just, respect your work so much. This ends our interview. It's certainly incredibly important work to inform all of us clinicians, telehealth developers, policymakers, administrators on how to best utilize and advance technology to provide equitable care to as many American citizens as possible. So big thank you, Dr. Bailey, for sitting down with me today. To read the full article and for other great articles like this, go to jmirpublications.com. As a reminder, JMIR is open access, which means that all of our articles are free to read around the world at any time. And as always, be sure to follow JMIR on Twitter, LinkedIn, Facebook, and YouTube.